Hello and welcome, everybody. It is good to be back. I've had an incredibly exciting week and a half. Went to the American Physical Therapy Association Combined Sections meeting in San Diego. And outside of being my favorite meeting, it was also the coldest I've ever been in Southern California because it was snowing in the hills of Los Angeles and San Diego, both with a tremendous amount of rain. So that was quite surprising. So great opportunity to meet with a lot of individuals, and we had probably the best reception I think we've ever had from physical therapists and universities. Our goal was to have 5 universities be interested, and we had almost over 30 universities that were interested in bringing Pilates into their schools. So I thought that was pretty cool. We got a lot to talk about today. We're going to talk about mobility of the ankle and the foot. And it's a topic that I love, working with dancers, having been a dancer, working with athletes. I fractured my ankle pole vaulting in college, many sprains, foot injuries, and just really being fascinated by the foot and how the foot responds, and in particular, the tools that we have as Pilates teachers and physical therapists to be able to manage these different types of injuries. And we really do have an incredible ability to do that. So just again, thinking of all of our tools. So today what I wanted to talk about is to do a little dive into anatomy, physiology, as I normally do, some biomechanics, some of the musculoskeletal components to the foot and ankle. And I want to talk on how can we better understand the properties of the foot and ankle and how it pertains to things like locomotion, acceleration, deceleration, balance and proprioception, and of course, stability. And remember, stability is the control of mobility. So we need to make sure that we have mobility first before we can really focus on stability. And I want to start more from a functional standpoint, looking at some slides that I've taken out of my book. And just another little plug here, we also launched the introduction of the new Principles of Movement book. The publication will be in hardcover coming out in May or June. But we were able to introduce it with the publisher this last week in San Diego, Slack Publishing. So some of the slides that I have in here do come from our book. So this first one here is looking at the actual heel strike and the different parts of movement that we have. Get my laser on here. And being able to understand how it is that how the foot dynamics change and the ankle dynamics change as we walk. And we're unique animals. We're bipedal animals. There are not very many bicurve biped animals other than humans. Even our primates tend to have a singular curve and have a very different lower extremity relationship than we do. So for example, our pelvis being a little more narrow, our femurs coming in at an angle, the Q angle, stacking on top of the tibias in a vertical position, and then the tibia and the fibula relating to the talus and the talus into the foot and ankle or the heel. So when we look at this, a couple key things I want to talk about, so when we go into the anatomy, it makes sense, is this is what we refer to as heel strike. So heel strike in the gait phase is when the heel sets down, first touchdown on the ground in front of us when we're walking. And in that heel strike, we typically are going to be in what we call supination. So if you notice the foot angle here in the forefoot is sort of turning out. That is a supinated position of the forefoot. And we're typically in a dorsiflexion of the ankle when we strike the heel. Then we go into what's called mid stance. Now, mid stance, the foot flattens out and what we would refer to as a pronation. So the big toe rolls down flat. Like if you look back here on heel strike, you can see the big toe is higher than the little toe. When we're on the ground in mid stance, they're obviously being impacted by the ground and they are at the same level. We can have, some people will respond with a flatter foot than others. Some will have a rigid arch, but theoretically, this is the soft spot of the foot. There's a very important reason why we have this ability here in mid stance for the foot to splay. We'll talk about that splaying, and that increases the surface area for us to have proprioception and awareness, being that that's really the only contact point our entire body has with the ground against gravity to know where we are in space, right? We obviously can use our eyes and our inner ear, but from a proprioceptive standpoint, it really is coming from the foot here. As the weight continues to shift forward, we go back into a little bit of supination and inversion in the hind foot in that pronated state. And there's a very important reason we're going to talk about this, is that it creates the rigidity of the foot for acceleration. So we could think of this also as the heel strike is deceleration, the mid stance is proprioception, and toe off is acceleration. So there is rigidity in the foot when we're in supination. There is softness in the foot when there is pronation. And we'll talk a lot about this as we go through. A couple of things I also wanted to bring up here is the idea of dynamic alignment of the feet. And I want to bring up the point that sometimes we get so caught up in the feet. So for example, I don't want to be a podiatrist in this situation, because podiatrists are pretty much just looking at the foot, ankle, and the lower leg. But if you look at these images, different relationships of the hip and the knees can have a direct effect on the foot. So if I treat only the foot, I could be accentuating problems that are existing in the knees and possibly even in the hips. And so when we look at our normal alignment, remember how I said the pelvis width leads to the femoral neck coming in at what we call the Q angle. So there's an angle here coming down of the femur into the knee. And that medial condyle on both these knees is larger than the lateral condyles on the outside. That's what allows us to be up straight. And if you think about it, this center of gravity, the sit bone, is coming down right on top of the knee, right on top of the ankle, right on top of that second toe. And we'll come back to alignment. But that sit bone, or that ischial tuberosity, is coming right over it. So the amount of movement to be centered literally is between the ischial tuberosity and the pubic symphysis. It might be an inch. So if we're standing with our feet together and we want to just pick up a foot, we only have to shift our pelvis in a healthy alignment, maybe an inch, maybe even a centimeter, right? And then that's all we got to do to be able to maintain that center of gravity over our feet because of this Q angle in the neck and the way that it comes in. Another way of looking at this is the head of the femur comes into the acetabulum, and its center is also right at the wing of the sacrum. So here I have the laser on the sacrum. It comes right into the edge of the sacrum in the back. And as I said, the center of the ischial tuberosity, or the sit bone. So that's just incredible design. Thank you, Heavenly Father, for that design. But the idea is that we really have this centering ability that other animals do not. And another day we'll save it for the spine, talking about the transition of the ground reaction force that then goes up through the pelvis into the lumbar, and particularly the thoracolumbar junction, to create reciprocity or reciprocal motion in the human being, which is also unique to us in our bicurve spine of any other mammal. So now let's take a look at what happens when we have abnormal relationships in our bones. So this example here is a varus knee, right? So the neck is shallower. We don't have the sharp angle coming in that we saw on the healthy lower extremity. And that out there is going to put a stress on the foot that you can imagine is going to create a stress on the foot and ankle of a supination and inversion of the hind foot. So that's just going to be because of the angle. You see this tibia coming down in this angle, it's going to want to turn the foot open into a supination or inversion in the hind foot. And just the opposite, here we have a valgus response, an over rotation response that comes in. That's we call knock-kneed or valgus. And that's going to create a valgus or a pronation stress on the foot, right? So if I come in here and I put an orthotic in these feet to try to correct the supination or the pronation, all I'm going to end up doing is accentuating the problem in the knees and the hips. And so a rule of legs, I guess, it's not a rule of thumbs, because thumbs don't have anything to do with your lower extremity. But the idea is that we want to focus on proximal or the pelvis first as we work through the extremities before we would look at doing some kind of orthotic intervention for the foot. We want to make sure that the hips and the knees are in their best and optimal alignment and function before we would go down and change something in the foot and ankle. And this, I think, is a common problem when we get too focused on foot and ankle, that we don't assume that there are other pathologies, other alignment issues up the kinetic chain. I'll give you a good example of this. I had a client years ago that had bilateral hip replacements simultaneously. And it was the old-fashioned kind where it was posterior. She was older, so they cut the rotator muscles, did not repair the rotator muscles. They put in a shallow or a small head femur prosthesis and told her she was fine and sent her home and did not have any rehabilitation or education. So here she is walking with a walker, and you can imagine without the rotators, her knees were going to look like this when she came in. And when she came to see me, the doctor's orders were to prepare her knees for bilateral total knee replacements, right? So when I started asking questions, and it was like, well, when did your knees start buckling like this? She goes, well, it was pretty much right after surgery. So I put her on the reformer, and I started working on alignment and realizing that she had lost the proper mechanics and mobility of her hips, not because she had the hip surgery, but because she never went through the rehabilitation. So this was hanging on these medial ligaments of her knee, and the bunion that she had in her toes that was actually causing the most pain was merely due to unrehabilitated or strengthened hips following bilateral hip replacement. And then the interesting thing, when you have a single hip replacement, you have the other leg that can teach the new hip how to perform and how to work. But if they both get done at the same time, there's a lack of proprioception, awareness, muscle strength, you can imagine. So here she is, 75 years old, coming in, and all we had to do was put her on the reformer, and we started working on some alignment, and she actually shipped up pretty close to this alignment. So she had normal alignment. She did not have bony anomalies. There was no external rotation or hip abduction. This is what Christopher Powers talks about in a lot of his research on knees out of USC. He talks about how probably the greatest contributing factor to knee pathology is probably due to poor hip abduction and external rotation, particularly in deceleration motions like heel strike or coming downstairs. These are the kind of things that cause that rotation and that valgus stress that we see. It's not always bony. A lot of times it's muscular weakness in the hip. So we want to rule that out, right? That's why I'm putting this in the front. Before we dive into the foot and ankle pathology, I want to make sure we understand that we check those hips and knees first before we even dive down into the foot and ankle. I have a question that's come up by Helen Whitaker. It says, have a client with osteoarthritis in the navicular and tibia with loss of cartilage in the joint. He doesn't want a fusion, but his pronation is distorted and inversion excessive and beginning to have knee and hip issues. What exercise are best for him? Helen, we will be talking about that throughout this, and particularly in the end. And if I don't make it clear enough, just pop that question back up again if there's still a question about that. All right. So with that, I guess pre-framing of hip or foot and ankle things, let's jump right into the ankle. And when we look at the hind foot of the ankle, a couple bones we look at obviously is the talus. We're going to look at the talus very closely because it has so much impact on how the ankle moves. We have the calcaneus, which is our heel bone. We have the navicular, which is like a ball and socket joint with the talus. You can see that right here, right? So here's the talus, the head of the talus. Here's the navicular. So if you thought of the foot being able to spin, that's why it can spin. So that medial foot can spin around like a ball and socket joint around the talus. And then we have the cuboid, which you might have heard people talking about a cuboid manipulation. I have a picture of that a little bit later on. But this is the cuboid that communicates with the fourth and fifth digits. And then we have the cuneiform or mid-tarsals that are communicating with the first, second, and third tarsal joints or toes and phalanges. Now, something important here are these two axes of ankle and subtalar motion. So it's important to understand that subtalar joint movements result in inversion and eversion. So if you think of this sort of in the forefoot, if the talus spins and the calcaneus spin in that direction, so this is going to be talus, cuboid, and navicular spinning in this angle, that is going to be an inversion, eversion motion of the hind foot. And we'll make that relationship to the pronation, supination of the forefoot on the next slide. But this is looking at the hind foot. So if I spin around this axis, that's going to be inversion and eversion. So in inversion, what I would see is the cuboid moving in this direction. And eversion, away, I would see the cuboid moving in this direction. So let's just do a little test here. You can write it into the chat. If you think the hind foot is going into inversion, what would be the typical response in the forefoot? Supination or pronation? So if the cuboid and talus are going into inversion, what do you think is happening to the forefoot? You can sort of see the heel bone coming in towards the center of the body. What influence would that have on the winding up of the forefoot? Any thoughts on that? You can write it into the chat. Yes, you are correct. Rosanna de Guzman, the first one, supination, and Elizabeth Marguerite. Yes, everybody else is seeing that. Supination. Now, that doesn't mean that's what occurs when the weight bearing's on it. It's what should occur, but that is the motion that takes place here in the subtalar joint. Now, above that, we have the tibia that covers the top of the talus and the medial side of the talus, and we have the fibula that covers just the lateral side of the talus. And in that, that's called the talocrural joint. So this is how the tibia and the fibula join and meet with the talus. And that axis is going to be dorsiflexion and plantar flexion. So these are the two motions that we're confident about in the hind foot. Is going to be ankle dorsiflexion and plantar flexion around this axis, the talocrural axis. And then we have eversion and inversion that are around the subtalar axis, basically the relationship between the cuboid, talus, and navicular. Okay, so that's responsible for inversion coming in, eversion going out. Let's take a look at the same foot, but now let's look at the forefoot axes, right? So what we have is a medial foot axis. It runs through the second toe, through the cuneiform, it runs through the navicular and the talus. And if I could turn the ankle sideways, what you would see is the angle is going from the talus towards the foot also in an inclination. All right, inclining. It's going down. So it's going from high talus down to the second toe. When we look at the lateral foot, it is a relationship of the cuboid the cuneiform. Did I say that right? No, I said that wrong. Cuboid with the calcaneus with the cuboid. I just had a little brain fart there. I apologize. So if we look at the lateral foot, is the calcaneus with the cuboid with the fourth and fifth digit. So these two axes are basically dealing with the pronation, supination of the forefoot, and also what I mentioned before, the splaying. So when we are in mid stance, the forefoot and the medial foot is going to go into pronation, and the foot is going to splay, and that splay increases our absorption of uneven surfaces and is responsible for proprioception. So that's where we have a lot of feedback that comes up through the foot. So let's just review this real quick. The midfoot axes, right, are going to be related to pronation and supination, as well as splaying. When the foot is weight bearing on the ground, it's going to spread apart so that it has greater surface area and has greater proprioception. If we go back a slide, we have our ankle dorsiflexion and plantar flexion at the talocrural axes, and we have inversion and eversion on the subtalar axis. So those are our axes for us to remember. As we go into a little more anatomy here, now we can see the relationship of the tibia right here, and the fibula on top of the talus, right? So the talus is a big player here, and there are what we call facets. Facet is tied to the word face, right? The face of the bone that has cartilage on it to articulate with the articulating surface or cartilage of the tibia, as well as with the fibula. So here's a nice little mechanical model of it, but theoretically, we are doing like a hinge joint over the talus, and we have stability of that from the tibia malleoli and the fibular malleoli. Okay, so they come down around it. Here you can see a cutaway. This would be the lateral malleolus. This is the medial malleolus of the tibia. Now, there's some interesting things here. This surface of the talus, to me, is fascinating. So we're looking at, this is the anterior, this is the posterior. So if we were looking at it, make sure we have that understanding, because I'm going to flip the picture around on the next slide. But the idea is anterior talus is wider than the posterior talus. And that's a very important reason for it that we're going to discuss, right? So anterior is wider, posterior is narrower. We have stability that comes between the tibia and the fibula. And it's also important to know that the ligaments in here are a syndesmosis. So these are really, really strong ligaments. People that damage these ligaments have incredible instability in their ankles, and often will end up with either a fusion or a screw, which was one of the questions that had come in the pre-questions of the webinar. So this is very important to understand. And most times what ends up happening is people will fracture their fibula before they actually tear this ligament and union joint between the fibula and the tibia. When I was pole vaulting in college, I had come down from a 15-foot vault into a box from a broken pole, and I had broken the fibula, and I had torn all the ligaments around the fibula in its relationship to the talus and also to the calcaneus. So I ended up having to have a surgery to fix that on the left ankle. So as I mentioned, I have a passion for this part of the body. And so when we look at this relationship between the talocrural joint, right? The crural is the cross between the tib and the fib, and the talo is the talus. Let's take it one step further, and we can look at it here in this picture. And again, we see this increased dome and angle of the talus anteriorly and decreased posteriorly. So imagine in this foot, this is going to be the fibula on the left, and it's going to be the tibia on the right, okay? And the tibia sits on top of here. So what I want you to imagine, as they go back to those original pictures we showed of heel strike. So in heel strike, there really is no real tension between the tibia and the fibula yet. But as we go down into mid stance, the middle of the bone comes right in between the short posterior dome and the wide anterior dome. So it's right here is where that weight's bearing. As I start to move into toe off, and the weight goes into that second toe, and the ankle goes into dorsiflexion, the tib fib move into the wide space on the talus. That's really important, because what happens here is the tension increases between the tib and the fib. This is important for the ability to accelerate or to toe off. Now, as that gets tight, what also happens is the tightness between the navicular, the middle cuneiform, and the second ray of the foot. So you can imagine, as I'm toeing off mechanically in a healthy foot, the foot goes into a little bit of supination, becomes rigid in a way in the forefoot that allows the elasticity in the back of the leg to propel us forward. That's the purpose of it, right? It's to accelerate us in our human gait form. That's very unique. We can see a little bit better in this next slide, right? So you can imagine as the foot goes into dorsiflexion, it's going to increase the tension between the tib fib. That's going to become taut, right? And it's going to hold on. It's going to make this joint rigid, the talocrural joint more rigid, going into a weight-bearing toe off. that dorsiflexion is also going to cause the rigidity to come down the second toe. Now, what I want us to focus on here is if I don't have that rigidity because I have an injury or I have an instability in this area, then what ends up happening is I pronate into my toe off and I never get the tension between the tib fib and I never get the supination tension on the second toe. So what happens to my propulsion? It disappears. I end up having to use all tendinous and muscular tension to be able to walk forward. So these individuals you'll quite often see will walk with their feet turned out and they will go side to side and they're always walking on their heels. They do not toe off. There's a very common, especially with morbid obesity pattern of walking. Also with people that have always just had real tight external rotators, people that have valgus knees, they cannot ever get into enough supination to be able to create the rigidity on this second ray to propel themselves. So they don't do well with running. And yet it might be something as simple as getting alignment of the kinetic chain in the hip and the knees and having more responsive there so that in their toe off, they are actually creating the rigidity of the tib fib as well as the forefoot into the second ray. And this is something when we're teaching Pilates, when we go up into onto the toes, some of us have so much fixation in our head from a ballet training that we don't want any sickling. Heaven forbid we sickle, right? But the reality is the normal mechanics of the foot is sickling. Sickling is supination of the forefoot that creates the rigidity to propel us forward. So in normal gait and running, we actually want that supination when we go into toe off. We want pronation when we go into mid stance, right? So let's think of that gait cycle again. We heel strike in supination, we move into pronation, mid stance, and we roll off again into supination, right? And it is the rigidity that happens in that joint that creates the stability and the elasticity of the tissues, as well as the fulcrum to propel us over the ground. Can't emphasize that enough. When we're looking at alignment, do not be super anal about making sure that in point position or up on their toes that there is no sickling. There should be a little bit of sickling. That would be a normal mechanic, right? Now in ballet, I remember getting hit with a stick because I needed to have that ankle right over the second toe for an aesthetic line, but that is not a biomechanical line. Let's move into intrinsic muscles of the foot. So when we look at intrinsic muscles of the foot, these actually help us a lot. And again, remember, there's a lot of elasticity, and what's not being depicted here that should be depicted, and Carol Davis would be maybe hitting me with a stick if she had a stick, is how important it is to understand the fascial component of the myofascial of these muscles. So when we look at this, this looks like all the fascia has been scraped away. That's not true. All the fascia is around. There's a plantar fascia on top of the intrinsic muscles of the foot that interact wholeheartedly between the bone, the tendon, the periosteum, all the way through the muscle of the foot to the tendons to the toes. And these muscles are primarily controlling some of the intrinsics of the foot, like the lumbricals of our hand. We have the capacity, the same musculature that is in our hands, the intrinsic musculature, is in our foot. So if you remember doing some of the things with Runity, with Juan Nieto and Blas Chamorro, we do a lot of foot intrinsic exercises to try to increase the proprioception as well as the elasticity of these tissues. And if you remember the lecture with Dr. Carol Davis, what just sort of blew my mind with her was talking about how the muscle filaments actually just increase the tension of the tensegrity or the elasticity of the connective tissue in the bones to be able to have more leverage, more force, the ability to propel the body or to decelerate the body in its movement. So one of the first things I do with foot and ankle problems is I start with foot intrinsic exercises. So that's going to be things like trying to lift up the big toe, trying to lift up the other digits with the big toe down, trying to play the piano with the toes both in and out, both directions, because I want to bring more awareness and more stiffness to some extent, more elasticity to these intrinsic foot muscles that have been shown to increase things like, arch height. So if we're not strengthening those, and curling things up is another really good one, to pull a towel with a weight on it on the floor with your toes and to bunch it up underneath the arch. Great way to start increasing the elasticity of the arch. There's a couple questions that came up. Christine Hartsfield asked the question, why does the cuboid displace so often? And she said that she also gets hit by the stick sometimes. I'm hoping that we don't do that anymore. I mean, that was traumatizing to me, getting hit with a stick. And, it made me try to tuck my beautiful butt under and not appreciate the fact of those natural curves that we have, that I used to have, I guess. Now my curve's a little different. But, the cuboid is an interesting place. Now think of, and maybe we just answered the question a little bit. Christine was saying, like, forcing ourselves in point to keep the ankle over the second toe and the weight bearing there. But typically what happens is that cuboid sublexes inferiorly. If we could see it from here, it's this bone right here that's sitting next to the fifth metatarsal. So you can imagine that if, somebody rolled over their fifth metatarsal, or they just had too much stress going through the foot up on that second metatarsal, that cuboid can just displace a little bit. And it is incredibly painful. And there's a technique called the cuboid whip. I have a picture of it a little bit later. And that helps a lot. But here's the problem. If we have laxity around the cuboid with the ligaments, and then it's like every time we go into that supination to toe off, that it is, potentially could be irritated again, right? So a lot of times what we do is once we correct it, we'll put a pad there. But more importantly is to get those foot intrinsics strong enough so that it doesn't subluxe anymore. And that's where I would spend most of my time, is making sure that it's in the right place, and then make sure that we strengthen it so that it articulates correctly and has good elasticity around it. And sometimes even we'll do a little post on it to keep it up and tape it up there for a couple weeks, just so that the ligaments can heal and the inflammation itself can decrease and strengthen up those loose ligaments around it. Another question or comment from Sarah Edwards. Hello, Sarah. Hopefully you're doing well in England. For a valgus presenting client, then, it is worthwhile doing a lot of footwork on the reformer in dorsiflexion to strengthen that area. One of the things I like to do, this is a great question, Sarah. I like to have the foot on the bar, right? The toes wrapped around the bar and the heels underneath, and having them initiate the movement by sending the heels under the bar. One of the things that I like about that is it works on that posterior side, and I can see how weak their rotators are. Eventually, I have to get them over to the chair, and particularly the lunge, where they're really weight bearing through that hip, and to make sure that they can maintain that knee in alignment, even with a modified load with those springs in the chair lunge, or going into an exercise I learned from Sherry Betts of doing the marriage proposal. A lot of you are familiar with in our testing, of having one leg in front of the other spread pretty far apart and being able to drop down and stand back up without the knee collapsing inside. And then Christopher Powers does something where you step down, single leg step down. And if the knee collapses into valgus, you know that your rotators are not performing correctly. They're not strong enough, or they're just not firing at the right time. So great question. One other question, Whitney Valvel. How are you, Whitney? Good to see your name as always. Plantar fasciitis. I mean, how many, you don't have to answer this, but how many of you know somebody or yourself have dealt with plantar fasciitis? So again, remember, the fascia is connecting right into the periosteum and continuous into the bone. And typically there's got to be a stress reason for that fascia to be irritated and inflamed. Now, with plantar fasciitis, the giveaway is you wake up in the morning and your first step feels like you're stepping on glass. You move it around for a little bit, you get it moving, and it gets better. And then again, if you've been sitting for a long time, you stand back up and you feel like somebody's sticking that knife back into your heel. And that's just an irritation that's happening. If we look here, it's going to be the plantar fascia comes over these lumbricals and the foot intrinsics of layer 1, and it attaches right here into the calcaneus. And what you have to think of is calcaneus, that plantar fascia is continuous with the fascia and the Achilles tendon, right? So the Achilles tendon comes down and wraps the calcaneus and just is continuous with the periosteum into that area. So there can be a number of reasons. Things that I typically want to look at is there some abnormal movement in the foot in that normal walking, heel strike, mid stance, toe off? Other things I look at is, do they have good mobility in that area? Do they have enough dorsiflexion, right? So that's one of my big signals that I always check for. If they don't have enough dorsiflexion, what happens to the tension going through the calcaneus in toe off? It goes up exponentially, right? So we need to have enough dorsiflexion to be able to balance that load into the Achilles tendon as well as in the plantar fascia. And if we don't have enough dorsiflexion, then we're putting a lot of load into the plantar fascia. Great questions, everybody. Let's continue the next layer of muscles for the foot and ankle. And this is our extrinsic foot muscles, right? So these are the muscles that are like our forearm. You could think of them exactly the same as forearm muscles. And so we have the ability for flexion extension of the ankle that's going to happen there, and flexion extension of the toes, the long tendons of the toes. We have the tibialis anterior, tibialis posterior. There was a question that came in ahead of time about problems with the tibialis posterior or an injury to the tibialis posterior. And remember that all of the posterior tendons could have an effect on plantar flexion. All of the anterior ones on dorsiflexion, right? So all the anterior ones, toe extensors, foot and ankle extensors, are all going to facilitate dorsiflexion, which will lead to another question, which is on drop foot. And plantar flexion is going to be all the posterior. So you have the gastroc, which does not cross the foot; it just goes down to the cuboid or calcaneus. And then you have the deeper muscles that we can see here. So here you see the soleus with the gastroc cut away, and then that is only covering the ankle, where the gastroc covers the knee and the ankle. We go down a little bit deeper, and now we have the tibialis posterior. We have the deep flexors, flexor digitorum longus, flexor hallucis longus, and the fibularis brevis here on the side. So these are the muscles that affect foot and toes, some of them, right? So the flexor digitorum, the flexor hallucis is the big toe that influence that movement, just like we have in our hands. It's almost identical, right? So what we have to find the balance is the balance between the foot intrinsic muscles and the foot extrinsic muscles. So one of the things I always like to look at is, do they have a normal balance between anterior, posterior, lateral, medial muscles and extrinsic and deep intrinsic muscles? And a good way of testing this is just on the reformer is so great, because we can put the jump board up and we can just change all different types of positions and orientations of the lower extremity. For example, if I put the heels down low close to the base of the jump board, I'm also now looking at what happens with hip extension. If I put it up higher, it's going to be a little bit easier. I bring the heels down lower, it's going to be harder for them, because maybe their hips don't have enough range of motion. And that tells us when they're standing, they're also cheating somehow on how they're dealing with these things, right? If you don't have enough hip extension and you don't have enough ankle dorsiflexion, those posterior tendons and the flexors deep in the foot and the plantar fascia are going to be overloaded. They're going to have an excessive amount of stress, right? And if you go out and you try to run with that, right, you could build up and you could accommodate. You could have compensation. Those muscles could be stronger, and the tendons and the periosteum could all get stronger, if you accommodate right. But we'd also like to think of, let's get a little more dorsiflexion and have a little more balance between anterior and posterior. Same thing with our hips, same things with our knees, same thing with our back, right? Everything should have agonist-antagonist balance. And when we think of physiology, this is exactly what everything I teach in physiology is about, is homeostasis, right? So we have the sympathetic and the parasympathetic system. We have hormones that that trigger things to be on and hormones that trigger things to be off, insulin and glucagon. So all of these things always are looking, our body's always looking to find homeostasis. And that includes the musculoskeletal system and especially our lower extremity, as you know, we're bipedal animals. Any questions about muscles or tendons before we continue on to the next round, looking a little bit at the nervous representation of the foot? I see a couple questions that have come up. Jenny Adams says, what's my opinion on orthotics and barefoot shoes for foot and ankle? That'll be the end of this program, and I'm excited to share and talk to you about that. I do have some thoughts on it. I'll tell you that they are pretty much my thoughts, and but we can talk about some of the research that is out there and also the research that is not out there regarding barefoot and orthotics. And then Liz Batty had a question. I have a client who had just had a full ankle replacement, just about start one-on-one sessions post-physio. Any suggestions? Now, probably the most important thing is that we understand the prosthesis, right? So the prosthesis of a total ankle is going to probably act more like a hinge joint. And that's what you need to do the investigation. So we can't create other arthrokinematic behaviors. This is what we also see in a total knee. That total knee typically is going to function more like a hinge joint than it's going to function we talk about the arthrokinematics of the spin, the glide, the shift that are all part of flexion extension of the knee. So first of all, learn what the prosthesis is, and then think of, what limitations are there because of that prosthesis. So there will be limitations in dorsiflexion. So how do we create accommodations for that? They might need a heel lift. They might need to really focus on hip extension to make sure they have enough hip extension. We might need to gradually strengthen out. And the Pilates, all of the footwork is fantastic for this, as well as the footwork on the chair. Foot intrinsics, getting the foot intrinsics nice and strong, are all things I would do with a total ankle replacement. Debbie Cristofano says, I have a couple clients with a rod in big toe to correct a bunion. Very common surgery by podiatrists. Everything up the chain is affected plus toe off. What recommendations for this? I mean, I try to, I hate to say this, and there are times when the podiatric surgeries really help. But when you mess with that first ray and bunionectomies, and I know a lot of people are doing better, but you're going to lose dorsiflexion. You're going to lose dorsiflexion. And if you lose dorsiflexion, it's going to force you to be a little bit more in supination when you should be a little bit more in neutral. So that supination could be a problem later on in other parts of the body. That's why you're saying like it goes up the knee, patellofemoral alignment, hip alignment, even spine, reciprocal motion coming up the spine can all be affected by that. So how do we deal with that? Well, I mean, you do want to optimize and understand what they did and what is an expected amount of dorsiflexion after that surgery. And then try to get that optimal dorsiflexion. You're not going to get more than it probably, but try to get what they expect to get out of it. Make sure that works well. And then you're going to have a little more mobility in the midfoot. Right? So if you don't have it in the big toe, it's got to come from somewhere if they're going to return to certain activities. The other possibility is just decrease their activities, which we don't like to do, right? So there are some ways to do that. I also like doing a little bit of taping. So you can use some K-tape or something like that can create a little bit more of awareness in other parts of the foot. So again, the foot intrinsics are very powerful for people that are having hammer toe surgeries, bunionectomies, fusions of the joints of the toe. Excuse me. Usually by the time they need to have those type of surgeries, we have a compensation in place. We're going to have to figure out a compensation strategy. The best thing we could do is try to work with them before they have those surgeries. So even though they might have bunions and they might have trigger fingers and toes and they might have hammer toes, it is so important to try to increase things like ankle dorsiflexion, to increase foot intrinsic strength before they would have the surgery. And a lot of times they don't even need to have the surgery. So just thinking of that. Let's keep going. A lot to cover. This next slide is looking at the homunculus in the brain, the sensory and the motor cortex. On the right-hand side, we're looking at the sensory side. This is the sensory. And you notice that the 3 or 4 largest representations in the brain is the hands, the lips of the face, then the foot, and then the genitalia, right? So those are the major sensory representations. So it's interesting that the foot is up in the top 3 of being represented in the sensory portion of the homunculus in the brain. We put shoes on, we put socks on, we stand on rubberized floors. Sometimes we can have as much as 3 centimeters of space between our foot and the ground. And one of the studies that was out there was saying that for every, millimeter of space that we distance our foot from the ground, we lose a percentage of proprioception coming into this part of the brain. So my point is that there is a tremendous amount of spatial representation in the sensory system for the foot. And that's responsible for a lot of the awareness. And I was mentioning is the importance of having as much contact with the ground as possible. Now, a lot of people interpreted that as, well, hey, let's get barefoot shoes and run barefoot. But if you've been wearing shoes with Nike soles and Asics soles and now Hoka soles for a long time, what we've done is we've softened our feet up. So our feet are not accommodating to the stresses that would happen on a rigid surface like concrete, right? So one of the things we suggested in Run-N-T was that you had a very gradual exposure to the stresses of barefoot running or minimal shoe running. So that should answer that question that there is, we want to, if we put too much stress on a soft foot, it's going to blow up and you're going to have all kinds of tendon and plantar fascia and toe injuries because the tissues have not accommodated that stress. So you can't just jump into that kind of behavior. So one of the things we suggest is we want you to get as close to the ground as possible. When I teach my Pilates classes, I have my students take their socks off so they can get as close to the floor. I have them stand off of the mat on the wooden floor so that they can have the greatest proprioception coming up in their body. When they do their foot intrinsics, I want them barefoot on a hard floor surface, not on a mat, to be able to build up that awareness. Let's keep moving. I do have a question here from Shelly Erickson. It says, was born with club feet that was surgically corrected by severing the Achilles tendon. Then as an adult, left foot had triple arthrodesis, that's a fusion, and right foot totally reconstructed. Lastly, I had bunion surgery on right foot. Footwork is wonderful for feet, and any recommendations. And, unfortunately, Shelly, when you've had that much surgery, like I've had some surgery on my ankle as well, we lose some of the mobility, and for some reasons we need to have that mobility taken away. Others, we get more mobility, and we just have to do the best we can do. I think that, again, with that type of surgical history, working on the foot intrinsics, working on thinking of the tensegrity model, working with different levels of tension and speed and tempo on the footwork on the reformer and things you do on the ground. You also might need to have shoes that are padded because the surgery and the fat pads on the foot might not tolerate that much ground reaction force. So you might be one that needs to have a little extra padding. And what you're going to sacrifice a little bit is going to be some of the proprioception that comes into the foot. And there's other ways to get that, but that would probably be my suggestion is foot intrinsics, work on mobility in the ankle and other parts of the body where you can, and then make sure you're protecting the soft tissues of your feet from too much ground reaction force, because wherever there's a fusion, like you said, in the left ankle or the bunions, that you are going to have increased stress going to the neighboring joints and ligaments and connective tissues. So we just got to be a little careful. Speaking of that, we're looking now at some different types. That was a perfect segue, by the way, Shelly. We're looking at different types of injuries, right? Or different types of pathologies. So we just mentioned congenital, which would be like the club feet. And there's still quite a few children being born with club feet. And the surgeries have become much more successful today than they were, 50, 60 years ago. That I remember having some friends in elementary school that had clubfoot surgeries. and they were much more aggressive in those surgeries and didn't have the same outcome as they do now. Other things that we see are fractures. So we see stress fractures. So a lot of times dancers, runners, the repetitive strain on the bones, maybe even some nutritional things as well can contribute to this. Also, amenorrhea can contribute. This is where a woman is very athletic or is in gymnastics and dancing many hours in their developing time, and they are amenorrheic. They don't have their natural monthly period, and they don't have the normal estrogen levels, and that can lead to some bone demineralization and stress fractures. Stress fractures also happen just from repetitive strain. So long distance runners, track athletes, basketball players, tennis players, anybody who's doing repeated acceleration, deceleration are subject to this. Some of the more common places of stress fracture can be in the tibia, right? Shin splints and stress fractures. It can be in the fifth metatarsal, and it could actually be in any of the long foot bones that we can see. And a lot of times our dancers would go in for a bone density screening, and it would show up where they would have a real high intake, meaning that there was an inflammation process going on in that bone. There was a stress fracture. So those are things that we treat by decreasing the stress. So what are the ways that we can do that? One of the most common ones is to put somebody in a boot or immobilize it and let the inflammation heal up. For us as Pilates teachers, we can completely control the amount of load going through the foot and through those bones. So we can take off 80% of gravity's effect on the body and still have a healthy amount of load going through those tissues while they're healing, and they will heal faster. So a lot of times you'll need to talk to the doctor and say, if I was to do a partial weight bearing, just like they would be wearing their boot, they're doing partial weight bearing, would you be okay with that? And that's a communication between the therapist and the doctor, or the Pilates teacher and the doctor. Traumatic fractures are, for example, the dancer that rolls over their fifth toe and they have a fifth metatarsal fracture, or like I had with the fibula fracture, or an ankle fracture, or bimalleolar fractures. So there's a lot of different fractures out there. The problem with these traumatic fractures is the scar tissue that follows. So it's important to, just be aware of the scar tissue. That's what we want to make sure as the bone heals that we're actually starting to introduce that movement earlier than later, to make sure that we don't lose too much dorsiflexion and plantar flexion for normal foot and ankle mechanics. Another common injury is sprains. We have grades of sprains. Usually the 1s and 2s heal up very well on their own for most people, but 3s and 4s typically include rupture of the ligaments, and that leads to often some loss of mobility as well as some loss of stability. And so those people will lose some of their proprioception. Reoccurring sprains is quite often for somebody that's had a level 3 or stage 4 sprain. And if I just ask this audience listening to me now, it's the most common injury, orthopedic injury, is a sprained ankle. And how many of you have had 2 sprained ankles, 3 sprained ankles, 4 sprained ankles? The more severe the sprained ankle, the less the proprioception. So if you're jumping up and you're coming onto land, you don't know where your foot is necessarily, because those lateral ligaments aren't telling you the stretch receptors of where the foot is in space. And so it's more likely to come down on the lateral foot and to sprain that foot. Strains and tendon ruptures, this is dealing with muscles and tendons. So Achilles tendon, different tendons could rupture of the hallux of the toes. I've seen ruptures of the posterior tibialis. I've seen ruptures of the gastroc, other injuries of those tendons that heal up quite well if we let them rest, and then we start restoring that natural movement. If it's a complete rupture, they'll need to have surgery. So I have 2 friends recently that had Achilles tendon ruptures, and both of them needed to have a pretty significant surgery, and it took them about a year to be able to get over that. The last thing I put here was neurological injuries, and that includes central and peripheral. So somebody could have a stroke, somebody could have brain injury, somebody could have multiple sclerosis that could affect the nerves that have sensory from the foot, as well as nerves that provide motor or strength to the foot. So this is where we might see things like foot drop, right? We might see things like spasticity or clonus in the foot and ankle. We might see some abnormal patterns of movement in these areas that have been affected by the nervous system. And one of the best things we can do is trust in neuroplasticity and keep providing the load in a very safe way. So for example, we don't want to overheat a patient with a neurological disorder. But Pilates is great for not overheating them. Like we could do multiple repetitions of footwork with really good proprioception information coming in from a closed chain environment that is going to have the greatest possibilities of helping them with neuroplasticity. In the case of a drop foot, the other thing that we have to think of, there's a number of tools we use as therapists. We use stimulators, we use ankle foot orthotics to be able to prevent from causing a tripping and falling accident, which is much more dangerous. So if I have a patient that has a real drop foot, either from a spine injury, it could be a disc injury that is putting pressure on the motor nerve, that could cause that weakness. So those are things that we look at. And peripherally, a lot of times when somebody has had damage to their leg, I know that with my fracture, I damaged the peroneal nerve a little bit. And so I still have a hypersensitivity around the fibula and a loss of sensory around that area as well. So there are the peripheral nerve injuries, and then there's the central nerve injuries. The key thing for us to believe in and to understand is neuroplasticity. The neuroplasticity, according to Andrew Huberman and some others, happens at nighttime while we're sleeping, and we have to create the demand for that neuroplasticity with the repetitive movements with proper alignment and load during the day so that we can get that neuroplasticity at nighttime when we're sleeping. All right, we're just about there. If you bear with me, we'll go a couple minutes over, but I wanted to talk a little bit about some interventions for foot and ankle. As I mentioned, in cases like fractures or serious tendon ruptures or sprains, we typically going to start with immobilization because those tissues have to heal up or be reconnected. The ligaments, the bone fracture might have to be set. So one of the treatments that really is legitimate is immobilization. I know I've heard people say that, we shouldn't immobilize. I'm somewhere in the middle. Like I like to get access to my patients as soon as possible. Even so if they're in a boot, I love boots because I can take a boot off and I can work with a partial weight bearing and then put the boot back on for them to make sure they're safe in their daily activities. A hard cast, I'll work the other leg or the other parts of the body while the cast is being immobilizing that foot and ankle. Where we really come in is mobilization. I think with what we talked about today of where movement comes from, where's the talocrural movement, that dorsiflexion? Where is the subtalar eversion, inversion coming from between the talus and the calcaneus? Where is pronation coming from on the medial axis and also on the lateral axis of the foot being able to splay and have balance? So any of those that we can restore, and this is why think of in the chair or the footwork on the reformer, we want to position the foot in as many different places as we can, particularly contact points with the ground. So the ball of the foot, the heel, and even a little bit the lateral metatarsal on the fifth side, we want to create different exposures to that. And we can even load the tissues that are healing, right? So let's say that somebody had a lateral sprain. We can put the foot, the heel on the foot bar, and we can have them sort of inverting and everting their foot a little bit in a partial weight bearing on the jump board or on the foot bar. So these are the kind of ways that we can restore some of that motion. Now, I show here also that, I could do a joint mobilization. This is a picture of a cuboid whip to get the cuboid back into place when it's subluxed inferiorly. Here's a picture of somebody being casted. But really what we're looking at, myofascial release on the plantar fascia. We're looking at understanding where the movement restriction is coming from and what is the safest way for us to restore it inside of our scope of practice. So I know a lot of you are familiar with Eric Franklin and Eric Franklin balls. I love using those and having patients use those for working on foot intrinsics, like just putting the ball of the foot on top of the ball and starting to wiggle the toes. It makes it a little bit easier than on the floor. And then gradually progress. We also have our Pilates foot corrector that we can work on that strengthens intrinsics. It also works on strengthening the extrinsic muscles of the foot and ankle. And then we can take it up another level where we're looking at really challenging proprioception on uneven surfaces like the RX mat or something like that. That question on orthotics that came out, remember I said I don't disbelieve in orthotics. I think they have a place. What I want to be careful of is going to orthotics too quickly when we haven't worked with the kinetic chain from the top down. But here you see an example of the ankle foot orthoses that I was talking about for foot drop, where this sort of supports, and there's a lot of different ones. Some are spring loaded, depending how bad the foot drop is or how bad the spasticity is in the plantar flexion, that this can prevent them from things like catching their toes on a rug and resulting in an injurious fall, right? That's the most common injury that happens with foot drop. So we want them to be safe when they're out and about, but when they're doing their Pilates, we take this off and we're working with them without it. We want to create as much load. We want them trying to do foot intrinsic exercises with the hope that they can re-educate and reestablish some of the connectivity of proprioception and motor into that part of the foot and ankle. Here we have the arch support, right? So this is just somebody who has that fallen arch. Again, I would not substitute this only and not do foot intrinsics. I would still do the foot intrinsics, and based on the pain that they're having, see if I can give them some relief with an arch support, only after I know that we've done all we can in the upper kinetic chain. And then down over here on this side, you can see where somebody that was supinated or inverted, using an orthotic wedge could help align that subtalar joint only if we've restored some of the normal alignment or optimized the alignment of the upper parts of the lower extremity. And then in this one was a pronation or eversion of the subtalar with a little lift that helped align that. So these are tools that we can use. They can be beneficial. I just don't want anybody to think that they're the end all, because if you are not dealing with the problems that are up above the kinetic chain, we're just making things worse. All right, that's all the slides that I have for today. I'd like to just answer some of the questions that came through. Mark Harrison said, how do you handle stress fractures on the fifth metatarsal? And so typically what has to happen here is there does need to be some level of immobilization. So they'll typically put them in a boot for about 4 to 6 weeks, hoping that that stress fracture heals up. At the same time, for me, like I like to do activities where I'm doing the Pilates on the heel or on the jump board with like a red and a blue spring only, and working on keeping a little bit of load in there, because one of the things we know is that bones have greater osteoblastic activity when there is load on them, right? So we can't put so much load on there that it aggravates the stress fracture. And this is sort of a high level determination of how much stress is appropriately. What I can tell you is even just doing foot intrinsics and doing work in the Pilates on the heel is going to provide a much faster recovery when the boot is legally able to come off at that 4 to 6 weeks, whatever the doctor prescribes. Hope that helps, Mark. Rosanna de Guzman said, regarding foot mechanics, if you're doing heel lowers or heel raises lying on the reformer and supine, can I clarify a bit of supination where the weight goes more towards the fourth and fifth? Ray, yeah, that's a great question. And clients to press into the bar with the first and fifth metatarsal head. So a couple different things there, Rosanna. The first one is that if you think of toe off, when you rise up onto your foot, we're going to expect the hind foot to go into a little bit of inversion, and we're going to expect the forefoot to go into a little bit of supination. So that's where the weight starts going from the second to the third metatarsal if we were doing a normal toe off, right, or walking on our toes. When we are in midfoot, we're expecting that weight to be splayed between both sides of the feet. So we want to work in that range as well. And then the last bit of that you talked about was just the idea of you can be on the jump board with your feet, and you can be doing all the intrinsics there right on the jump board, lifting the big toe up, lifting the fifth metatarsal up, lifting the middle 3 toes up, bringing them back down, lift the fourth and the fifth and first up. And those are just for reference. If we go to some of our Runity exercises and videos, if you've been the Runity program, or if you want to get some of those, we can send you some links to those videos, I believe. I'll ask Melissa if we can do that. But those go through a whole set of how we do our foot intrinsic exercises. Teresa Maldonado, my dear friend, how are you? Given what you said about dancers and the incorrect weight focus in plantar flexion, how would you cue them to be more biomechanically correct yet maintain their desired aesthetic? It's going to be a little bit biased, Teresa, and I know you've worked with dancers in the past. And what we're thinking of is like, can we still again, think of the different kind of feet, right? A Grecian toe versus a, what's the other one? I always think of like chopped toes, where the toes are like perfectly level versus those that have a long second toe. That can make a big difference in this kind of work, especially if you are a ballet dancer and you're dancing on point shoes, right? You have to have your box of the shoe extra padded to be able to manage that. One of the things that I look at is, I want to see that align between the second and third toe and the ankle and the patella. So that's sort of my visual cue of alignment. Now, there's going to be variations. Not everybody's going to fall into that pattern, but those are things that I typically look at in plantar flexion. And in ballet, we tend to try to push it between the second and the first toe. So what I would do is I would be content if they could keep it relatively over the second toe, right? So normal would be sort of second to third. Ballet wants it on in between the first and second. I'm saying, see if you can bring it just into the second. You're still going to have a pretty good line. You're not going to notice it sickling. You're not going to be collapsing laterally on that ankle. Olga, from where comes the V Pilates position? And I'm not sure which V Pilates position you're referring to is talking about the first position for Joseph Pilates, I think is what you're probably referring to, Olga. And Joe did not, with the dancers, like them in full turnout. So there was a V position is what I think you're referring to, where the feet were at about 45 degrees of an angle to 90 degrees, but not more than that, right? And that's where he would work on trying to strengthen the lateral rotators of the hip and the hip extensors, right? And we said Christopher Power's study showed that weak rotators and weak extensors were what led to sort of malalignment of the knee in deceleration and load. And so I'm pretty sure Joe was onto that. I've never seen anything written about it, so I'm just speculating. But that V position is when you're going down into your squats is basically challenging that. I do this with my Tai Chi exercise, where I go down into a partial squat and I open up 45 degrees and come back, keeping the knee straight forward on the standing leg, strengthening up the rotators and the abductors and extensors of the hip. And it's a great exercise. So that V position is crucial. Azita, talking about neuromas, and neuromas typically is an inflammation of the nerve and vascular bundle between the second and first, or the second and third toe. And again, it's an inflammation process. If it's bad enough, there's some treatments where they can do cryotherapy, where they freeze it, or they do a surgery and they remove some of that bundle, which will decrease some of the sensation. But those are the typical things there. The question I would have is, why are they having so much pinching? Now, a lot of times that's because the shoes are too tight. So if you don't have a good box on your shoes, you're going to be squeezing too tight. For example, high heel shoes with pointy toes, perfect playground for neuromas to get inflamed in the toe. So just something to think about. Good shoe boxes, good foot dexterity. If you do get a neuroma, minimize the inflammation on it, stay out of tight toe shoes, and keep the foot intrinsics up. Lisa Venter, my daughter has flat feet, but her toes are all curled up. What can she do to change this? I would get the Franklin ball, and I would start working on the Franklin balls, or the small, maybe about a 3-inch width or diameter ball, and just working the toes and trying to get the toes starting to move, and then starting to go into things that you can do on the reformer, or just stretching those toes if they're curled a little bit, and trying to get a little more dexterity in that foot. I'm not sure how old your daughter is, but typically children are much more pliable than they are when they're, in their 20s. And then one last question from Mark Harrison, how to handle pain below and in front of the medial malleoli when ankle dorsiflexion is limited. I didn't get a chance to talk about that, but Mark, this is a great question. I learned something from Marika Molnar about 30 years ago, and I use it all the time. And it's the fibula, after an ankle injury or a sprain, often gets stuck, and it gets stuck down. So the dorsiflexion is just going to keep irritating that space there in that lateral ankle that you're talking about. So one of the things that I do as a manual therapist is I drop my thumb into the space between the tibia and fibula, and I have them point and flex their ankle. And I just work my way down from the knee down to the ankle. And usually after doing that once or twice as a manual therapist, that fibula now starts gliding up and down, and that lateral ankle or lateral knee pain seem to dissipate. And that's a pretty cool thing. Like, I've had some very frustrated patients that have had total knee replacements and knee surgery because of lateral knee pain, and nobody thought to go back far enough and ask them, if they'd ever had a lateral ankle sprain, or to check the mobility of the fibula. Remember, the fibula up by the knee is where the hamstring attaches to that head, and then down at the ankle is where that lateral malleoli, and a lot of times the sprain, looseness or instability from the sprains of the talocrural ligament. And so that's a really cool little trick. So maybe we'll talk about that another day, or we can put some examples of that up. But that's basically mobilizing the fibula and making sure that it glides up and down. And I can't tell you how good of a response we get on that so often. All right, that's all I have for today, and good to be back. We'll see you again next week. Again, we got a couple things happening. We have that critical reasoning online workshop. So Melissa will send that out in the post-production, so keep your eyes open for it. If you're interested, you can join us from anywhere. It'll be recorded and take it later. It doesn't take the place of the live course, which we have happening next week. So if you're still within, a quick flight or a drive to North Carolina to our Polestar Life Center on the farm, we'd still love to have you. We have some space available. You could talk to Mylin or connect with any of our Polestar representatives. And that course is live. We bring in live patients and clients that we work with together, 2-to-1. So every two students will have one client to be able to work with and to go through the problem solving and assessment, really sharpening your critical reasoning skills as Pilates teachers. That's all I got for you today. Above all things, I remind you, be kind, have a great weekend, and we'll see you next week at the next Polestar Pilates Hour. Thank you for your patronage, and please share it with a friend.